So next we have Dr. Charu. She is a very needs no introduction and a very known practitioner of retina in Delhi, and she will be telling us about the next modality, that is OCT.
So at the outset, I'd like to thank AIOS and Guliani sir for giving me this opportunity. I'll be talking about OCT biomarkers in retinal vascular diseases, and I'll be restricting to diabetic macular edema because of the paucity of time. Biomarkers, we know it's a merged term for biological markers which are a sign of that indicate the health of a individual or a disease. And there could be various biomarkers like anatomical, chemical, molecular, and imaging. We're going to talk about the imaging biomarkers. We've already discussed FFA, autofluorescence. OCT is what we're going to go to next. And biomarkers are important because these are a very easily acquired modality which helps us predict the visual outcome and helps us in decision making regarding the treatment options, because we have whole plethora of treatment options available at our disposal these days. So OCT, we all know, has revolutionized the way we treat retinal diseases. And the advantage with OCT is that it is a non-contact, non-invasive imaging modality in which we can study the retina layer by layer, and it enables to characterize the retinal pathology in all details. Apart from the OCT biomarkers, OCT also helps us in identifying the morphology of the macular edema, and that itself guides us how we're going to treat the patient. Like we can see here, is the pointer working? Can I have the pointer, please? So we can see here, this is a center involving spongy macular edema here, a non-center involving macular edema. This is how we classify the DME these days, the cystoid macular edema, and if we see this vitromacular traction at the retina and the vitreous interface, the whole treatment that we are going to plan changes. This is an example of a patient with a spongy macular edema with the central subfield thickness of 567 micron, was treated with anti-VEGF, a clear-cut case, resolved beautifully, and with the non-center involving macular edema part left, we took up for the focal laser, and the patient macular edema resolved very nicely. Then again, that one modality, we know that all others could be treated with anti-VEGFs and lasers, but once the vitromacular interface comes into picture and there's a VMT, we know the surgery is the answer to this patient. So this was a non-compliant patient with a very taut, almost tabletop kind of a macular edema. We took up the patient for surgery, and the patient improved fairly after 4 weeks of surgery. Coming to the OCT biomarkers, these are the various OCT biomarkers that we're going to be talking about one after the other. Central subfield thickness, here we are basically looking at the macular thickness map, and this is the ETDRS circle which you can see in this picture here, which we get in all our scans. This is the central 1 millimeter followed by 3 millimeter and the 6 millimeter circle. It is the central 1 millimeter that is the point of interest for each one of us. It is the severity of the central subfield thickness. The more the central subfield thickness, it signifies that the severity of the disease is also more, and so is the duration. So it is the percentage of decrease of thickness on treatment is a very good predictive thing of response to treatment, and it is a useful anatomical marker to diagnose and monitor. But central subfield thickness, as earlier thought, is neither prognostic nor predictive of the visual outcome. On the contrary, the central foveal choroidal thickness is a very good predictor of visual acuity, because if the subfoveal choroidal thickness is good, that means that the perfusion is very good and the response to treatment will be good. As I said, the central subfield macular thickness is not a very good predictor of visual acuity, and on the contrary, 26% of the patients go into having rather a lower visual acuity after treatment, which is called as paradoxical vision. So we can see here, this is a patient with a large cystoid macular edema just sitting over the fovea, and with treatment, whereas all the fluid has resolved, still the patient hasn't gained a complete 6-on-6 vision, and there is whole disorganization of the retina, all of the other biomarkers that we will be talking about subsequently. So the central subfield thickness increases because of intraretinal or subretinal fluid, and fluid, whenever it is present, it is evidence of disease activity. Fluid can be either intraretinal or subretinal. Whenever there is intraretinal fluid, the prognosis is worse. We can see in these pictures, these are pockets of intraretinal fluid, more concentrated in the outer retinal layers, and this is a mixed kind of a picture with intraretinal fluid and some amount of subretinal fluid. When this intraretinal fluid is present as cysts, we call it intraretinal cystoid spaces. The number, location, and the size of the cyst matters here. When the cysts are more than 200 micron and they are present in the outer retinal layer, they become significant because the outcome really, it can really hamper the outcome, because as you can see here, this is a large cyst sitting more than 200 micron in the outer retina, and here it starts compromising the outer blood retinal barrier, that is the external limiting membrane, and the ellipsoid zone, and that is where we know that the outcome will probably not be as good. What is more important than the number, size, and the location of the cyst are the bridging retinal processes. These are residual neural tissues that are connecting the outer and the inner retina and transmitting the visual impulses. So here you can see in these both pictures that we can see these bridging retinal processes on the OCT, and on resolution the retinal integrity is also being maintained. So these are good prognostic signs. When we have bridging retinal processes, the outcomes are also good. On the contrary, you can see here in this case, there are no bridging retinal processes in this large cyst. And on resolution, it has just led to all disorganization of the retinal layers, and the visual acuity is, that is achieved eventually is not good. Another example with bridging retinal processes are cystoid macular edema. Cystoid macular edemas respond very well to steroids. We have known that there is probably an inflammatory component that goes in here. This was a patient who was treated with dexamethasone implant. Subsequently, all of the edema resolved and eventually was taken up for anti-VEGF later, and patient gained a visual acuity of 6.6. He started with 660 whereas. So the other kind of macular edema is the neurosensory detachment, or the subfoveal neurosensory detachment as we call it. 15 to 30% of the DME patients have SND. As far as the results or the prognostication of SND is concerned, there is a lot of ambiguity. There are certain studies that say some amount of subretinal fluid is protective and is a good prognosticating sign, whereas others say any fluid should not be tolerated and should be treated, and we should achieve a good drying. So here you can see this is a patient with a mixed macular edema with some intraretinal edema and the neurosensory detachment here with the fluid space here. This is another example of the same with some intraretinal cyst with a subretinal fluid which responded beautifully to steroid and almost melting away of completely of the fluid that is there. The other biomarker that we come to is hyperreflective retinal foci. These are aggregation of lipoproteins and inflammatory cells which are thought to have extravasated due to breakdown of the outer blood retinal barrier, and they appear as intraretinal hyperreflective foci. They are typically less than 30 microns in size, and here I have put in this circle to show you this is a hard exudate that has a back shadowing, whereas all the HRFs you can see they do not have any back shadowing. And whenever hyperreflective foci are present, these are signs of poor prognosis. Whenever they are present at the onset, we know that the visual acuity outcome will not be as good. So more so, they can be present in all the retinal layers, but whenever they are present in the outer retinal layers, the prognosis is further worse. And so on, going ahead, when these hyperreflective foci are present in the choroidal layers known as hyperreflective choroidal foci, it is what we realize is they are believed to have migrated from the retina to the choroid due to the disruption of the outer retinal layers, and again suggesting a poor prognosis in these cases. So talking about the outer retinal layers and the inner retina, the disorganization of the retina that is happening because of this is defined as boundaries, loss of boundaries between the layers of the retina. That is the ganglion cell, inner plexiform, inner nuclear, and the outer plexiform layer. And it is the central 1 millimeter again that is most important here. How do we identify drill? If we see an OCT here, you can see that we can identify all the layers separately each one from the other, whereas this part shows that all the layers of the inner retina are all disorganized and we can't make out each one apart from the other. So this is associated with a worse visual outcome and is also have been said to suggest ischemia of the retina. This is another example where the macular edema has resolved beautifully, but here you can see in the outer part still you can identify the layers separately, but in the central 1 millimeter zone, all the layers, the pattern has been lost, and this is a characteristic example of drill. The outer retinal layers, in the outer, the external limiting membrane is a very important layer because it is an outer blood retinal barrier, and whenever this gets compromised, the next is the photoreceptors that may get affected, and thus is a very good predictor of the visual outcome. The next layer, of course, is the earlier known as the ISOS junction, now known as the ellipsoid zone. So these two layers, the external limiting membrane and the ellipsoid zones, are of much concern. Whenever they are lost, the prognosis becomes poor, and the percentage of disruption of these layers significantly predicts the visual outcome and is known as drawl, or the disorganization of the outer retinal layers, and we grade it, it is a grade 2 drawl when the ellipsoid zone as well as the ELM both are disrupted, as we can see in this case. Pearl necklace sign is a sign of chronic exudative maculopathy, and in this we see that there are contiguous hyperreflective dots which are lining the inner layer of the cavity. As we can see in this case, the macular edema has resolved, but we see this cystic space lined by these hyperreflective foci. This is a characteristic pearl necklace sign, and this is the place where we know that we do not have to keep pushing intravitreal injections any further. They won't have any much effect because this is not fluid, but this is just the accumulation of macrophages and lipoproteins which have come in to line this cystic cavity, which is not going to budge with more injections. Parallelism is a new sign which we know that retinal layers are aligned parallel to each other, and whenever the parallelism is lost, we know that there is some disease activity. Just one mention about the retinal vascular occlusions. DME and RVO have a same pathophysiology more or less, and so they share most of the biomarkers, whereas CRVO could have more of an ischemic component, so biomarkers there become very different or may not have as much relevance. The vascular occlusions in the macular edema resolves beautifully, and most of the times the retinal architecture is very beautifully retained here. So OCT is a very good imaging biomarker, and the central subfield thickness, which was earlier considered a very significant biomarker, we know it has only modest correlation to visual outcome, but it is of course a good prognostic sign of the treatment that we are doing. The response of treatment can be monitored very well. The other biomarkers, drill, drawl, HRF, are all much more robust biomarkers as far as prognosis is concerned. And again, just to re-emphasize, these biomarkers make our life much more easier by helping us predict the visual outcome and deciding which treatment modality will work best for our patients. Thank you.
Thank you, Dr. Charu. Any questions you have, Dr. Charu?
Slide off?
Parallelism
Yeah,
slide.
sure.
यार एक मिनट
could you
दोबारा
just
से लगाना प्रोजेक्टर ना सेकंड लास्ट स्लाइड मैडम के
No, I'll do it myself. Yeah, there it is. Yeah.
Achha, I have only one question for you. If you see subretinal fluid, I was under the impression that we must treat it as early as possible. But today you confused me by saying that we should or we should not.
So, sir, there are various studies that say that some amount of subretinal fluid could be protective for the retina.
Studies nahi. I just want in your experience.
Sir, in AMD we can tolerate some fluid still, but in diabetic macular edema we would mostly want to have a dry retina. In AMD they say some amount of subretinal fluid could be protective, and it is a good prognostic sign if it is present in the beginning.
Dr. Vinay, what about you?
Sir, I think this fluid thing is more about the AMDs, and what challenge that we've seen with periodic injections of anti-VEGF is sometimes they go into geographic atrophy. So therefore, if you're trying to chase and remove each and every droplet of fluid from there, you may end up causing more of geographic atrophy. Therefore, there they say a bit of subretinal fluid, if it is there, don't chase it. But in a diabetic, because we are not, we don't get the geographic atrophy wala concerns so much, and we are not giving as many injections as we do in AMD, there I agree with Charu, we would like to treat. But in a AMD, there's a slight bit of subretinal fluid is left, we'll let it be.
Okay, thank you. So next we have Dr. Mayank. You have a question? No.
I just want to be a part of that debate that to me neurosensory detachment, any bit of it is a biomarker of disease and the metabolic status of the patient also. So I believe such patients needs attention. You need to halt, investigate their metabolic status, address it and then treat aggressively.
Yeah, so the cause of subretinal fluid could be different in AMD and DME.
Yes.
You know, you need to look up the retinal status, the inflammatory part of it in a DME patient. Whereas in an AMD, as Sir said, maybe we could be a little tolerant towards a little amount of subretinal fluid.
I agree. So DME, we need to chase the metabolic status, correct and try it.